Personalized medicine in COPD means tailoring our treatment according to the needs of each individual patient. We do have the same goals for most, and that would be to reduce symptoms and risk of exacerbations. It is good that the recommended basis for initiating treatment for our COPD patients are the same parameters. These are the domains of degree of symptoms and a patient's risk for exacerbations. The different pharmacologic classes we then get to choose from when we start treatment for our COPD patients are preferably inhaler medications that will provide sustained bronchodilation to reduce symptoms and exacerbations. So we have the LAMAs, the LABAs, the combined LAMA-LABA, and inhaled corticosteroids sometimes are combined also with inhaled bronchodilators. And we have the triple therapy fixed dose combination of inhaled steroids together with LAMA-LABA. Our 2021 GOLD guidelines recommend that we still start off with inhaled bronchodilator therapy, be it single or dual. So if the patient has persistent dyspnea with one bronchodilator, then it should be escalated to two. Our GOLD 2021 guidelines would recommend that we do add on inhaled corticosteroids only when it is in combination with a bronchodilator as well, and preferably if there would be history of exacerbations despite appropriate long-acting bronchodilator. We have to be cognizant of the side effect of pneumonia when we add on ICS, and it should be used only as initial therapy after possible clinical benefits versus risks have been considered. So if a patient is already on LABA-LAMA, it can be escalated to the addition of an inhaled corticosteroid if there are future or there are further exacerbations that happen among our patients and if their blood eosinophil count is on the high side. And this we will discuss further in the next couple of minutes. All these recommendations are, of course, still based on our knowledge of what COPD is. So we know that the main pathology in COPD is the persistent airflow limitation. But we are after the treatable causes. And therefore, our bronchodilators are logically still the first line treatment because that would be the treatable part of COPD, the bronchoconstriction. But we also try to target the airway inflammation because we know that contributes to the bronchoconstriction and airflow limitation and damage in the airways of our COPD patients. So for the past decades, we've had the knowledge that the airway inflammation in COPD is different from that of asthma. It is more of the neutrophilic and the TCD8 type of inflammation versus the eosinophilic inflammation in asthma. Therefore, this leads now to the lack of response or a less response to inhaled corticosteroids among COPD patients versus the asthmatics. And yes, the seminal study of Dr. Hug et al. Several years back would attest to that. When they did biopsies on the airways of COPD patients, they indeed saw that there was a predominance of neutrophils and your CD8 T cell type. But we can see that there is also the presence of eosinophils in the airway inflammation among COPD patients. But in contrast with asthma, therefore, the pharmacologic treatment response among our COPD patients to inhaled steroids won't be that much because of the neutrophilic type of inflammation that we see among COPD patients. But in a small proportion of these COPD patients, around 15%, where eosinophilic inflammation might be more predominant or be dominant, then inhaled corticosteroids may be effective. So this revival in the interest on the effect of inhaled corticosteroids in COPD patients in relation to the presence of eosinophilic inflammation, and this is either assessed through the eosinophils in the sputum or the eosinophils in the blood, was revived by mainly two authors at the start, Dr. Buffadel and Dr. Pasco. So Dr. Buffadel's study looking at ICS-LABA in the budesonide formoterol combination versus LABA alone, she was able to show that those who had a higher eosinophil count among the COPD patients had fewer exacerbations when inhaled steroids were also on board in their treatment regimen versus LABA alone. And she saw this to be more predominant when the eosinophil count was zero point 0.2 times 10 to the 9 or more. In Dr. Pasco's study, where they looked at triple therapy with fluticasone furoate as the inhaled corticosteroid combined either with LABA alone or LAMA-LABA, they were also able to see that patients who had a higher eosinophil count responded more to the presence of inhaled steroids in their regimen with a decrease in the number of exacerbations versus those who had no steroids on board in their treatment. And he saw that the cutoff in terms of the eosinophil count was more or less at the 300 absolute eosinophil count level. But both would attest to the fact that the response to inhaled steroids seems to be in a continuous fashion with a trend of a higher eosinophil count portending a better ICS response in terms of decreasing exacerbation rate. So after then, there have been already several studies on the fixed dose combination of inhaled steroids on board on top of LAMA-LABA with the different types of molecular combinations. And the meta-analysis has already been done on this. And true enough, the meta-analysis would show that the presence of inhaled steroids on top of LABA-LAMA or on top of another single long-acting bronchodilator would show that if we are after a decrease in exacerbation, then there is a consistent signal that it does indeed lead to a 25% risk in reduction or 25 reduction in the risk for COPD exacerbations if inhaled steroids are on board. But we have to be also cognizant of the fact that the COPD patients in these studies were of the more severe type, where they were frequent exacerbators and had poorer lung function. And some studies also showed, for example, the impact study of Dr. Lipson. It showed that there might also be a signal of a decrease in mortality if inhaled steroids were on board. But this meta-analysis gathered all those triple therapy studies where inhaled steroids were on top of LAMA-LABA. And overall, their conclusion was there was no significant difference in mortality, but there was a trend favoring less mortality if inhaled steroids were combined with LAMA-LABA. And as I mentioned, most of the non-significant mortality benefit was powered by the impact study that I mentioned. And that impact study, unfortunately, just ran for 12 months and was not specifically powered to examine the difference in mortality. And therefore, the gold guidelines, as we can see later, would have some qualifications as to the outcome of a mortality benefit with the addition of inhaled steroids. Now, how about the outcome of dyspnea? Will adding inhaled steroids to bronchodilators lead to less dyspnea overall for our patients? So again, in this meta-analysis, we can see here that there was no such signal. Triple therapy versus LAMA-LABA combined or LAMA alone showed no significant difference in dyspnea or quality of life. And we have to remember that there would be that safety issue when we add on our inhaled corticosteroids in the treatment regimen of our COPD patients. It has been known to be associated with an increased risk of osteoporosis, pneumonia, diabetes, and cataract. And the mechanisms that they have looked into why this happens there are several, but mainly probably the use of inhaled steroids would impair the immunity in the respiratory epithelium, lessening its integrity as well, and leading now to more episodes of pneumonia or even viral infections with a decrease in the interferon beta release from the immune cells that participate in the epithelial integrity and immunity. So there are several mechanisms, and so far, all these recent studies using triple therapy inhaled steroids combined with lama would consistently still show the fact that pneumonia is indeed a risk that can happen when you introduce inhaled steroids into the regimen of your COPD patients. In fact, there is a computed 47% increased risk for pneumonia with the triple therapy trials combined in this meta-analysis. There is also a meta-analysis before that showed that there might also be a risk of increase in TB reactivation or TB disease among patients who are on inhaled steroids among COPD patients. But if we think now of all the TB cases, then we can say that the presence of TB that could be attributable to inhaled steroid use isn't really that much, so that this meta-analysis concludes there is no population-based intervention that is warranted. But when we consider now our individual patient, if there is an untreated TB, for example, we have to be wary about that and also monitor probably the possible tuberculosis condition of our patient. The next thing they were looking at was in terms of blood eosinophils being related to the treatment response among our COPD patients is, are there other factors that can affect or can lead, that can be associated with eosinophil use and its response to inhaled steroids? So one of the studies would be this one. And here they were able to show that in their multivariate analysis, the presence actually of fewer eosinophils in the airway epithelium or in the and also in the blood of our patients actually is a risk factor possibly for increased risk of pneumonia happening among our COPD patients. And also they found that chronic bacterial infection would also portend to a higher risk of pneumonia for COPD patients. They also looked at the use of inhaled corticosteroids in this study, and they were not able to consistently show a signal that inhaled steroid use per se led to pneumonia in this observational study. So what is striking here would be fewer blood eosinophil count can be a risk factor to having more pneumonia among our COPD patients. Now, this other study also showed the link or the relationship between eosinophils and the tendency probably to have pneumonia or to have more pathogenic bacteria in the respiratory epithelium. In this study, if you will note, they looked at sputum eosinophil, not blood. And they now looked at its association with the presence of potentially pathogenic microorganisms. And again, we can see here those with fewer sputum eosinophil count had actually here a higher tendency to have more pathogens in their respiratory mucosa versus those who had a higher sputum eosinophil count. So how do we now get all these together? Our last speaker, Dr. Dave Singh, has this theory, and this is a very nice diagram, probably now to link everything together. So what he is proposing is that our patients probably who have higher eosinophil counts, be it in the blood or in the sputum, would probably have a T2 helper type of inflammation going on. And this now makes them more responsive to inhaled corticosteroid treatment. So then there would be a greater inhaled corticosteroid response versus those who have a lower blood eosinophil count and fewer sputum eosinophils, then they would have probably have a neutrophilic type of inflammation. And this preponderance of neutrophilic rather than eosinophilic inflammation would now make a patient be more prone or susceptible to have bacterial infection because probably they have more pathogenic microbes in their respiratory epithelium to begin with. And therefore, they would have a smaller inhaled corticosteroid response in terms of decreasing exacerbation. And there would be now that safety issue that they might now be more prone to have pneumonia when they have a lesser blood eosinophil count and they are also using inhaled corticosteroids as well. So this is, as I mentioned at the first part of my talk, this is now the recommendation of Gold 2021 as to how we should now think about using inhaled corticosteroids in our COPD patients. So yes, it can improve outcomes such as decrease in exacerbations, be it combined with LAMA-LABA or with LABA alone. And our Gold 2021, as I mentioned, put this statement that recent data suggests a beneficial effect versus fixed dose LAMA-LABA on mortality. But again, mind you, we saw the meta-analysis. It was just based on one big study there, most of the positive signal. And we consider this as a beneficial outcome for those who are symptomatic and with a history of frequent or severe exacerbations. And very important, it remains to be evidence A that regular treatment with inhaled steroids can increase the risk of pneumonia, especially those with severe disease. Therefore, our GOLD guidelines would still recommend that when we initiate treatment for our COPD patients, we still have the bronchodilators inhaled as our first line treatment, be it as single or as a dual therapy with LAMA and LABA combined. And it is only those in the group D category, that means those who are frequent exacerbators and have more symptoms, and if their eosinophil count in the blood is 300 per microliter or more, should we consider adding inhaled corticosteroid on top of their bronchodilator therapy. And the things that we have discussed so far are summarized in this table. Again, to emphasize that probably we should not have inhaled corticosteroids on as part of the treatment regimen of our COPD patients. If they have had repeated pneumonia events, that means there might be a lot of pathogenic microbes there, and the addition of inhaled corticosteroids now can further impair the respiratory epithelium immunity or immune response to these infection. And if the blood eosinophil count is less than 100, and as we saw from that meta-analysis, a history of mycobacterial infection that might reactivate or has been untreated so far. Otherwise, we have discussed this already, the cutoff that they would now advocate where we do consider adding on inhaled steroids if our patients are frequent exacerbators too, would be the count of 300 cells per microliter. So if our patients are already on medication, when do we add on inhaled steroids? So it is interesting to note that our GOLD guidelines would recommend such. If our patients continue to suffer from worsening dyspnea, actually there is the option to stop inhaled steroids, to remove it, and to switch or to maintain your combination LAMA-LABA treatment. So here again, the reasoning is inhaled steroids did not lead to the outcome really of an overall improvement in dyspnea. But if our patient is suffering from frequent exacerbations despite treatment with bronchodilators, then this is the indication where inhaled steroids are added on, as we can see here, especially if the eosinophil count is 100 per microliter or more in terms of the blood count. So the GOLD 2021 recommendation has also this new statement here. They say that for COPD patients who are heavy or current smokers, they do not have the same benefit from ICS use on lung function and exacerbation rate compared to light or ex-smokers. And it is, again, the study of Dr. Pasco, which was the basis for that recommendation. Here we can see among the current smokers that those who had a fewer eosinophils or blood eosinophils in their count actually did not have a decrease in exacerbation rate, and therefore the treatment response was not seen. Whereas the former smokers did show a benefit in terms of inhaled corticosteroid use in terms of the number of exacerbations being reduced. So the statement here is the magnitude of inhaled corticosteroid benefit increased with higher blood eosinophil counts, both for former and current smokers, but in current smokers, if they had lower eosinophil counts below 200, that was the cutoff that they saw here, there was no benefit with the use of inhaled corticosteroid. So I mentioned that it is possible to withdraw inhaled steroids actually from the regimen of our COPD patients. And one such organization, our big European Respiratory Society, have the following details as to when we consider withdrawing inhaled corticosteroids. So there would be a strong recommendation that or that we withdraw inhaled corticosteroids if our patient would have actually a lower eosinophil count and they are not suffering from frequent exacerbation. So here, aside from lung function, aside from looking at the symptoms of our patient, aside from looking at the risk of future exacerbation, we now have another parameter in mind that we can use. Some would call it a biomarker, and that would be our blood eosinophil count. This can help us tailor or personalize the treatment for our COPD patients as to when we consider adding on inhaled corticosteroids or even removing it when we think it is not necessary. I mentioned at the start that still, bottom line, first line treatment would be our inhaled bronchodilators. And if we are looking at cost effectivity as an important outcome for our patients because their medications are sustained and they can really be expensive, one such study where they compared LABA-LAMA in the form of tiotropium olodaterol to triple therapy where inhaled steroids were on board would show that the cost with LAMA-LABA alone, with tiotropium olodaterol, in terms of the total cost, the medical cost, and pharmacy cost, compared to triple therapy where inhaled steroids is added onto LAMA-LABA, would actually be less. So patients would be spending less if they are on LAMA-LABA versus triple therapy. And in terms of the COPD and pneumonia-related medical costs, these would also be less when patients are on LAMA-LABA versus triple therapy. So to summarize, 3 is not necessarily better than 2 or 1, or triple therapy with ICS on top of LAMA-LABA versus LAMA-LABA alone or versus a single bronchodilator need not necessarily be better for all our COPD patients. We do have to tailor and personalize. And one such tool we can use to help us at least now gauge who would be a good responder to addition of inhaled corticosteroids would be the use of blood eosinophils. So how do we do this? Just get the CBC and then look now at your WBC, the total number there, and then multiply it with the percentage of eosinophils that is present in your CBC result. That can help us now. So if our patients would have an absolute eosinophil count of 300 or more, they would most likely benefit from addition of ICS. And those who would have a less than 100 eosinophil count will probably not benefit from that. And in between, it will now be a judgment call on us. And again, we consider this for those patients who are frequent exacerbators and are quite symptomatic. So to summarize, ICS-containing treatment may provide benefit for a select population or patients with COPD with the eosinophil count of 300 or more and recent history of frequent exacerbations. Use of ICS is associated with an increased risk of side effects in patients with COPD, such as pneumonia happening, and infrequent exacerbations with eosinophil counts of less than 300 should switch to bronchodilator therapy, be it single or combination LABA-LAMA. Long-acting bronchodilators are the basis of COPD treatment. And real-world findings we've seen highlight that there is a lower economic cost and clinical burden with combination of LAMA-LABA such as tiotropium olodaterol compared to fixed-dose combination of triple therapy with an inhaled steroid on board as well. So thank you, everybody. I hope you've learned a lot as to how to